you for that introduction. I am from Adelaide, so I'll be pronouncing graph as graph, but I should be otherwise understandable. So this is my research, same but different, and it looks at the prevalence of dysglycemic states in the critically ill and then the impact of chronic hyperglycemia on the interaction between ICU blood glucose and mortality. So hyperglycemia occurs frequently in ICU, and it may be due to either diabetes, recognised or unrecognised, or due to stress hyperglycemia. And stress hyperglycemia occurs in non-diabetic patients who have normal glucose tolerance, who then become hyperglycemic in ICU, which then resolves following resolution of their acute illness. In the last decade, there have been major trials that have looked at the adequate or optimal blood glucose thresholds in the critically ill. But despite these trials, such as the Leuven study and Nice Sugar study, we actually have limited prevalence data on these conditions, largely because they've failed to discriminate between unrecognised diabetes and stress hyperglycemia. And this may be important as there's a body of evidence that suggests that hyperglycemia in ICU doesn't represent the same insult to all patients, and that for patients who are diabetic and chronically hyperglycemic, they may actually tolerate hyperglycemia better during critical illness, and in fact it may be protective. Much of this work is from retrospective studies from Professor Plummer's group, and this is one of such study that took ICU patients, both diabetic and non-diabetic. On the x-axis of this graph, we have an indicator of their ICU blood glucose, and on the y-axis, ICU mortality. So for patients who are not diabetic, shown here in red, both hypo and hyperglycemia is associated with an increase in ICU mortality. But for the diabetic cohort, only hypoglycemia was associated with an increase in ICU mortality. In extension of this work, again in a retrospective study of diabetic ICU patients, Professor Plummer's group stratified their diabetic cohort according to their chronic control. So that was the HbA1c shown on the x-axis, and on the y-axis we have a measure of their ICU blood glucose. And he divided the patients into hospital survivors and hospital non-survivors. And what this shows is that for diabetic patients who have poor control, so HbA1c is greater than 7%, there's a greater proportion of hospital survivors with higher blood glucose than those with lower blood glucose, which suggests that hyperglycemia may have a protective effect in this diabetic group. So the aims of this study were to determine the prevalence, particularly of stress hyperglycemia and undiagnosed or unrecognised diabetes in the critically ill, and then to prospectively evaluate the impact of premorbid glycemia on the association between acute ICU hyperglycemia and outcome. And our hypothesis was that acute hypoglycemia during the first 48 hours of admission would not be associated with increased mortality in those patients who are chronically hypoglycemic, so those patients who have poorly controlled diabetes. So this was a prospective observational study that I conducted over 12 months and gained ethics approval from the Royal Adelaide Hospital and had informed consent waived. So that allowed us to enrol 1,000 consecutive patients into the Royal Adelaide ICU who are over the age of 18. We collected the demographic data shown, and importantly, we took a glycated haemoglobin. So we took an HbA1c on the admission bloods and then recorded the blood glucose measurements in the first 48 hours. And on those two parameters, we stratified patients into 4 groups. We defined hyperglycemia according to the American Diabetes Inpatient Guidelines, which is also consistent with the WHO guidelines, as a fasting blood glucose greater than or equal to 7, or any blood glucose greater than 11. So stress hyperglycemic patients had a non-diabetic HbA1c, so less than 6.5%, and had an episode of hypoglycemia. Recognised diabetes was any previous diagnosis of glucose intolerance other than gestational diabetes. Unrecognised diabetes were those patients who had an HbA1c greater than or equal to 6.5% and no history of diabetes. And we confirmed this by speaking to the families and also calling the general practitioner of all of these patients. Normoglycemic patients had a non-diabetic HbA1c and no episodes of acute hypoglycemia. Parametric and non-parametric data was analysed as appropriate, and we developed a logistic regression model with the interaction terms of HbA1c as a measure of chronic blood glucose control, peak blood glucose in the first 48 hours as a measure of acute glycemia, and hospital mortality. And the adequacy of this model was assessed by the Hosmer and Lemeshaw goodness of fit test, which is a standard test to assess adequacy of logistic regression. So I begin by presenting the prevalence data, and what this shows is that hyperglycemia is exceedingly common in the critically ill. So nearly 50% of our patients had stress hyperglycemia, and over 25% of the patients were diabetic, of which 5.5% had unrecognised diabetes. And that's considered probably slightly higher than the rate of unrecognised diabetes in the Adelaide population, which is thought to be about 3 to 4%. Only 22% of patients had normal glucose tolerance. Of the diabetic patients, this was predominantly a type 2 diabetic phenomenon, so only 11 of the patients had type 1 diabetes. Those patients who were diabetic compared to non-diabetic tended to be sicker, older and have larger BMIs. Normoglycemic patients, compared to any patient with a dysglycemic state, so stress hyperglycemia or diabetes, tended to be more well, so less catecholamine requirements, shorter ICU length of stays and fewer deaths. We then went on to have a look at the diabetic group in a little more detail, and based on the American and European Diabetes Association guidelines, classified them according to their chronic control as stringently controlled, those with an HbA1c less than 6%, adequately controlled between 6 and 7%, and insufficiently controlled with HbA1cs greater than 7%. So those patients could be considered chronically hyperglycemic in the community prior to coming into ICU. Of our 275 diabetic patients, there were fairly even numbers between those who had insufficiently controlled diabetes or adequately controlled diabetes or better. When comparing the insufficiently controlled group to the adequately controlled or better group, they were comparable in age, BMI and severity of illness, and their outcomes were comparable, so there was no difference in ICU or hospital length of stay or ICU and hospital mortality. And this is despite the insignificantly controlled group having significantly higher peak blood glucose, so 15 versus 11.5, supporting the hypothesis that hyperglycemia does not represent the same insult to all patients. So we then went on to look at the logistic regression model, and again, the interaction terms on this graph are hospital predicted mortality on the y-axis, acute peak blood glucose on the x-axis, and then chronic hyperglycemia, or a measure of that, as the HbA1c. What this graph shows is that for patients who are non-diabetic or who have adequately controlled diabetes, there's a very, very strong association between how high their blood glucose gets in ICU and the predicted mortality, predicted hospital mortality, such that for every increase in blood glucose of 1 millimole per litre, there was a 20% increase in predicted hospital mortality. And that's consistent with the Leuven trials and nice sugar trials, and is why we start patients on intravenous insulin. The very contentious and I think very interesting part of this study was that for patients who have chronic hyperglycemia, who have HbA1cs greater than 7%, shown here in green, this association is lost. So even in the extremes of ICU hyperglycemia, so 20 to 30 millimoles per litre, in this logistic regression model, there was no increase in predicted hospital mortality. We then went on to adjust the model for potential confounders, so age, BMI, severity of illness, and admission category being medical or surgical. The model was still a good fit, according to Hosmer and Lemeshaw, but the interaction between our terms was no longer significant. So we had a trend at a p-value of 0.13. Now, we don't want to overinterpret this data, and this figure was included as a supplement in the eventual publication, but for those patients who have an HbA1c greater than 7% and chronic hyperglycemia, the slope is actually downward sloping, which would suggest potentially that hypoglycemia may have a protective effect. So strengths of this study, it is a relatively large sample size, and it is the first prospective study to accurately define the prevalence of unrecognised diabetes and stress hyperglycemia in the critically ill, particularly as we confirmed the GPs of our 55 unrecognised diabetics to confirm that that diagnosis had not been made. There are a number of limitations. It is a single centre study, and there are factors which can alter the HbA1c which we didn't exclude, such as haemoglobinopathies and blood transfusions, although hopefully that was minimised by taking the first blood on admission to the ICU. We use peak blood glucose as our sole metric of glycaemic control, and that has been shown to correlate well to a patient's ICU stay glucose control. However, other metrics such as average time-weighted mean blood glucose may have been of more value. And it may be that the complexity of the relationship that we showed may be more complex for those patients who have really poorly controlled diabetes. So in the community, if they run 20 to 30 millimoles per litre regularly and have HbA1cs in the teens, which we did see in some of our patients, it may be that they tolerate hyperglycemia even better, or in fact it may be protective, but we weren't able to tease that out, just categorising the patients as we did. So in summary, hyperglycemia is common. Stress hyperglycemia occurred in up to 50% of patients in our ICU, and more than 25% had diabetes, of which 5.5% is unrecognised. Certainly, for those patients who are not diabetic or who have well-controlled diabetes, acute hyperglycemia is associated with an increase in mortality. However, this association was not evident in those patients who are insufficiently controlled and chronically hyperglycemic. So these preliminary data certainly justify studies to target different acute glucose levels according to the degree of a patient's premorbid glycaemia. At the moment, all comers are targeted to the same blood glucose threshold, so 6 to 10 in our ICU, whether they're normoglycemic, newly diagnosed type 1 diabetics, newly diagnosed type 2 diabetics, or have been diabetic for decades and run blood glucoses in 20. And I think that that hypothesis now needs to be prospectively tested. I would like to thank my co-investigators, in particular my supervisor, Adam Dean, and the funding, so the funding through the Diabetes Australia Research Trust grant and my funding through an NHMRC scholarship. Thank you.